When you use the loop technique, you can actually use two different techniques: integrate retrograde wire together with the balloon passage. You can also use a wire only to get the integrate retrograde passage and then follow up with a balloon passage integrate. And I'll show you some examples in the next slide. This is actually one of the first cases that I did already several years ago in a patient with an occlusion of the posterior tibial artery, as you can see here in the proximal segment. There was also a long segment stenosis of the perineal artery indicated by the red arrows here. And you can already see a collateral connection in the supramalleolar area with the posterior tibial artery that actually gives a very good runoff towards the distality. In this case, it was not possible to recanalize the short occlusion proximally with a integrate approach. So I started improving the outflow towards the distality by performing a balloon angioplasty. And here you can see midway the procedure, the flow towards distal is already improving. And then a distal PTA was performed, and now you can see the connection and the crossing of the wire towards proximal, and then following up with the balloon, as you can see here, tracking nicely through this large collateral. You need a large collateral to be able to do this. And then you can perform your procedure up until the proximal part, as you can see here, and this is the final angiographic outcome. A second case, very complex lesion, heavily calcified, as you will see later. This is a occlusion of the tibioperineal trunk, and the main artery that we needed to focus on was the posterior tibial artery. There was a distal cap that was concave from a retrograde approach, and here was not possible to get into the tibioperineal trunk from integrate. There was actually no stump. And you can see a collateral here. This is not the tibioperineal trunk. You can see a collateral here all the way down towards the perineal artery. And then here you can see the posterior tibial artery. That is relatively of a good quality. I cannulated with a balloon catheter the collateral, as you can see here. And then with no 1/4 guide wire, it was possible to advance the guide wire back into the proximal part of the perineal artery up until the tibioperineal trunk. Here you can see the bifurcation itself, and you can see how heavily calcified the TP trunk is, as well as the origin of the anterior tibial artery and the distal segment of the popliteal artery. The next step is then to advance your balloon catheter, and this is a 2x40 balloon, which was actually not really tracking quite well. These are balloons that have a relatively blunt tip, and for that reason I exchanged for an Armada XT, which is a CTO balloon catheter with a very tapered tip, long tapered tip, and this, as you can see here, now follows without any problem. And then we have the wire tracking and going back into the popliteal artery, as you can see here. At this point, a balloon inflation was performed, as you can see here. And then after this, a 4 French diagnostic catheter was inserted over the 014 guide wire. And I always take a 4 French diagnostic catheter with an 038 lumen, which easily accommodates 2 014 guide wires. So leaving the first wire in place after the balloon angioplasty of the TP trunk, it's now very easy to follow up with the guide wire towards distal. Then you can remove the first guide wire that was going across the collateral, and you can leave your wire in place, your second wire in place, in order to deliver your final therapy. This is the final result. In the end, I managed to get back into the posterior tibial artery. I left the perineal artery for what it was. And here we needed bailout stenting in order to get this good direct flow towards the posterior tibial artery. So this was a combination of a wire and balloon in order to recanalize. Most of the time, however, the collaterals are too small to allow balloon passage, and for that reason, I have used a lot the wire-only technique. This is actually the first case many years ago that I performed, and I share this with you because you can see the two tiny collaterals in a patient with an occlusion of the posterior tibial artery, anterior tibial artery, and the perineal artery, as you can see here. This artery was recanalized in an antegrade fashion, but here you can see the common problem of the absence of a stump. The artery is ending in two collaterals, and the largest is this one, which connected distally with the perineal artery, as you can see here in more detail. These collaterals are of course too small and too tortuous to navigate with a balloon, and that's why I inserted again a 014 guide wire with a coaxial catheter system. This is the diagnostic catheter with a microcatheter already inside. At that time I still used a pro-grade microcatheter that we typically use for embolization, but we now have much more dedicated material available. All the support catheters 014 compatible that are on the market nowadays, and that mainly come from our friends in interventional cardiology for trans-septal recanalization. You can see the wire now navigating, going first into the perineal trunk distally, and then I was able to redirect the wire towards the proximal segment, as you can see here, then looping in the proximal part of the occlusion, and then just crossing with the loop towards proximal. And then after removal of the microcatheter, using again a 4 French diagnostic catheter, you can accommodate easily 2 014 guide wires, and then the pathway that has been created by the loop is easily crossed in an antegrade fashion with the second guide wire that now navigates easily towards the distal segment, first into the collateral and then back into the perineal artery. Then delivery from above from an antegrade fashion, and here you can see the final angiographic outcome in the proximal segment. After this, you can get a little bit more aggressive by using collaterals. This is a patient with a single vessel runoff and a short stump of the anterior tibial artery that you can see here, a relatively large collateral towards the dorsalis pedis coming from the anterior segment of the perineal artery, and here you can see the dorsalis pedis and a posterior collateral towards the plantar circulation. Of course, in a case like this, we always need to try antegrade first. I tried a antegrade approach with a balloon support, inflating a short balloon inside the stump in order to get some extra pushability. That didn't work out, as you can see here. You can see that the wire is backing out and the pushing out also the balloon catheter when advancing the guide wire. So here we needed to try to find another solution. You can see a microcatheter being used going into the anterior collateral of the perineal artery, crossing back into the anterior tibial artery, and here you can see with a loop formation in order to dissect without a risk of perforation, then following up, as you can see here, with the microcatheter all the way down and then back up again. Here you can see the support catheter now sitting at the origin of the anterior tibial artery, and now the connection towards the proximal segment is made. What you can do in these cases is try to snare the wire, but that would really require a larger bore sheath. I do a lot of my cases on an ambulatory basis, and I try to stay as low profile as possible. That's why I typically stay with a 4 French. And although it's a little bit more cumbersome manipulation-wise, you can still manage these cases with a 4 French approach. If you remove your support catheter at this point, insert a 4 French catheter on the first guide wire, and then, as I already demonstrated you, with the second guide wire, perform the antegrade crossing. And it's always amazing to see how the crossing of the wire in a retrograde fashion allows you to perform the antegrade recanalization and recanalization afterwards without a problem. Then, of course, you need to connect towards distally. You can follow the guide wire all the way down. Here it goes back into the collateral initially again, and then back into the dorsalis pedis. And then you can perform the rest of your procedure in an antegrade fashion, as you can see here. And here you can see the final angiographic outcome with still preservation of the distal vasculature and the distal collateral. Of course, it's very important to work very carefully not to lose this collateral, especially if it's one of the last. Therefore, I would recommend not to start with difficult cases like this, but use cases where the collaterals are not really very important, as in the first case that I showed you. Here another patient, again a single vessel runoff, and the target vessel in this case was the anterior tibial artery and the dorsalis pedis that you can see here. A occlusion after several centimeters in the anterior tibial artery. And as already mentioned, I try always antegrade first, just like I'd never try first initially with a retrograde stick. Here you can see the recanalization with a technique that I use a lot. Instead of going with an aggressive guide wire, I loop a relatively soft guide wire, and in this way you avoid or you lower the risk of a perforation. However, coming towards the distality, in this case it was not possible to remain intraluminal, and you can see the perforation of the dorsalis pedis at this point. Even if this patient had a or needed a revascularization of the anterior circulation, and the posterior tibial artery was not of a good quality either, I managed to get all the way down into the posterior tibial artery afterwards, and you can see injection of contrast now indicating that I'm still intraluminal. There's a small collateral that you see filling here, and then it was possible to advance the guide wire, and again a short balloon, the Armada XT, which is the CTO balloon that I already mentioned before. And then it was relatively easy, again with a looped technique, as you can see here, to follow through the distal arch back into the dorsalis pedis, as you can see on the right hand side on the non-subtracted image. And here actually navigation was relatively easy with a loop that went almost automatically into the dorsalis pedis. Then of course we need to connect again. In this case it was not possible to advance everything further up, and here you can see the initial guide wire that was still left in place, and the second guide wire that was present through the pedal arch trying to connect. You can see the wire coming from the pedal arch, so from the posterior tibial artery through the foot, going back up again, going back up into the popliteal artery, as you can see here, and then it's always an issue to get your connection back into an antegrade fashion. So here we have again my 4 French sheath, 2014 guide wires. Here you can still see the 4 French diagnostic catheter sticking out, and here you can see one of the guide wires in an integrate, the one in the integrate fashion that I used into the posterior tibial artery that I then used to reconnect afterwards. Here you can see the CXI catheter that I inserted integrately. This is the wire that went all the way through the posterior tibial artery, through the foot, and then back up again. And I now managed to cannulate the wire into the CXI catheter, and then it was possible to advance the CXI all the way down towards the foot, as you can see here. So going back again, these two wires were left in place, and the wire that was the wire that was supposed to go into the anterior tibial artery was used to cannulate afterwards the wire, as you can see here. Then the wire ended up in the anterior tibial circulation, angioplasty was performed, and here you can see now direct flow towards the forefoot, and the posterior tibial artery was dilated, didn't open up, and was left in this way, also because the patient had a lesion that required mainly anterior circulation. To summarize, if you start using the loop technique, start simple, know your anatomy, use the collaterals that you see on the lower leg segment, but know your anatomy, especially in the pedal circulation, know the principal connections between the anterior and the posterior circulation, but also by using distal angiography, identify any other connections that there may be. If you have these complex connections between the anterior and the posterior circulation, optimize your projection in order to really be sure which way to go with your guide wire. Know your material and compatibility, and in this way you can also keep your sheath size down to 4 or 5 French without resorting to 6 French systems. Of course, you can do a lot as well with 6 French devices, but I think if you can stay 4 French, this is much better. Use support catheters, and this can also be small CTO balloon catheters, and change between wires, navigational versus support, escalate, de-escalate. And I think when you perform procedures like this, one thing is very important: try to be creative.